Regarding the rest of the topography of the head and neck, we divide the region of the head and the region of the neck to the several other regions and a smaller region and triangles for better explanation of the structure in this area. As you see in this region of the head, we have we classified the region of the head to the head region and the face region. That already you had a lecture about the neurocranium and the splachnocranium, which is the brain part of the skull and the face part of the skull. Regarding the neurocranial part, is divided by the bones that they are making this calva or calvaria, which is the frontal region, parietal region, the posteriorly is occipital region and temporal region. And there are some smaller area that you have it in the area of the ear, so it's auricular region, and the place of the mastoid process is the mastoid region. Then the splachnocranium or the face part of the head is subdivided to the smaller region, orbital region. Small area under that is the infraorbital region. Then lateral to that is zygomatic region. Below is anteriorly buccal region, and posteriorly is the parotido masseteric region, which is important. And if you go to the midline, you have the nasal region, oral region, and mental region. So those are the face part of the head, which is subdivided to the smaller region. And for each smaller region, you have to know the borders and you have to know the content of each region. And then finally, the neck region, we classified it to the anterior cervical region, which is bounded by the two sternocleidomastoid muscle, and down with the jugular fossa and upward with the mandible. And this anterior cervical region is subdivided to the submental triangle, submandibular triangle, carotid triangle, omotrachal triangle, or muscular triangle here in this region. Then we have a specific region that is the place that the sternocleidomastoid is located there. So itself, it has its own region, the place that is originated here and is inserted there. So it's called the sternocleidomastoid region. And this muscle is making a boundary between the anterior and lateral cervical region, which is between the posterior margin of the sternocleidomastoid and anterior margin of the trapezius. So here, this region is called lateral cervical region. In some English literature, this part is called the posterior cervical region, but it's better to nomenclature, I think, is the lateral cervical region. And this lateral cervical region, by the pathway of the omohyoid muscle, is subdivided to two smaller triangles. One is the omoclavicular triangle, or is called the major supraclavicular fossa, and the other one is the omotrapezoid triangle, is the larger one, and in English terminology here also is called the occipital triangle also. And behind the anterior margin of the trapezius muscle, then posteriorly you will have the posterior cervical region, which is seen here in this region, which is here is clearly you can see the neurocranial part of the skull, which is the occipital region and parietal region and some part of temporal. And then there is a posterior cervical region. So those are the classification that you have it about the previous picture and the cervical region. You have the different and separate video that is uploaded in the MUDr. And now we are going through the region of the head, specifically in the neurocranial part, in the lecture of the neurocranium. You know that the calva or calvaria, it's the upper part of the skull and is made by the parietal bone and the squamous part of the temporal, occipital, and the temporal, occipital, and the frontal, and also the greater wing of the sphenoid bone. We discussed it that this part of the neurocranium, so it means that any of this region that you get it, and this is from the previous lecture, you have it, I just put it for refreshment, that whenever you get the region of the frontal, parietal, occipital, temporal region, which is a neurocranium or calva part, so you immediately after the explanation of the region, you have to say what's the layer. And the layer, we discussed it before, that is called the scalp, and according to the first letter of each layer is coming a skin, dense connective tissue, epicranial aponeurosis, or galea aponeurosis, loose connective tissue, and pericranium. Those are the 5 layers of the scalp from superficial to deep, and is valid for all part of the neurocranium. So any region of the neurocranium that you got, you will start with these layers of the scalp. And then after the description of this layer, then of course we said that the first 3 layers, they are called scalp proper because they are attached together and they make one unit together. And when you are touching your scalp region, so it's movable. So these 3 layers against the bone, which is covered by the pericranium or periosteum. So it's moving this 3 layer against this bone, and this 3 layer is called a scalp proper. Then you explain this scalp region, and then of course you have to know the border. When we are talking about the topography, you have to know what is the line which is separating the neurocranium here, which is green, with the splanchocranium, which is, or visceral cranium, which is yellow. This line is coming from the external acoustic meatus parallel with the zygomatic arch, and it's going to the supraorbital margin, and it's finishing to the nasofrontal suture or the root of the nose. So this line is exactly separating upward the neurocranium and downward the splanchocranium. Then you have to know the border between the complete head. It means including the neurocranium and splanchocranium from the neck. And there are 2 border, and one is superficial border, which is again is starting from the back side, from the external occipital protuberance, which is here, and then it continue parallel with the superior nuchal line, and it continue to the mastoid process or the external acoustic meatus, both, or the tip. Then it's continued to the posterior margin of the ramus of the mandible and the inferior margin of the body of the mandible, and then it goes to the chin region, and here is finishing. So this line, or this line that you can see here, they are separating the head region from the neck region, and neck region down from the thoracic region is separated via the suprasternal notch or jugular notch, which is going parallel with the clavicle to the acromion, and via the spine of the scapula is finishing to the spinous process of the C7 vertebra prominence, which has the large spinous process that you have it. So this line is separating is a superficial line which is separating the neck region from the thorax. So this is the topography. As you mentioned about the layers of the scalp, then of course you have to know, and you have to know each region is innervated by which nerve, each region is supplied by which artery, what is the venous drainage of the each region, and what is the lymphoid or lymphatic drainage of each region. Yes? So of course the nervous system still you are not, but this slide is showing and summarizing the nerves that they are innervating which part of the scalp region, and it will be helpful for your future revision. So usually the scalp region, we have the line which is called either interauricular line, it means the line is connecting 2 auricle together, or the point of the border is vertex, is the highest part of the skull. So what is in front of the vertex, they are innervated by mainly the branch of the trigeminal nerve, which are mainly the supratrochlear and supraorbital nerve, and the small portion is also by the zygomatico-temporal nerve branch of the zygomatic, which is the second branch of the trigeminal nerve. And also the last one is the auriculotemporal nerve in this area, which is innervating mainly the lateral aspect of the skull, which is the temporal region. So these nerves that you have here, they are responsible for the sensitive innervation of the scalp, the 5 layers that you mentioned. And then you have to say the frontal region is innervated by the supratrochlear, supraorbital, small part of the frontal, and the temporal part, mainly the temporal part, is zygomatico-temporal. Then the small area of the temple is the zygomato, and the larger area of the temporal region it's innervated by auriculotemporal nerve, which is branch of mandibular. Then posteriorly, from the vertex backside, it's innervated by the several nerves that they are coming from the spinal cord level, usually C2 and C3, which are some of them it's the ventral branch, and some of them they are the dorsal branch of the spinal nerve. The greater occipital nerve and the lesser occipital nerve, these two nerves, they are arising from the cervical plexus, which are coming from arising from the anterior branch of the spinal nerve C2, C3, and for the lesser occipital C2, they are innervating the posterior aspect or occipital region and posterior aspect of the parietal region. And also we have the dorsal branch of the spinal nerve C2, which is called greater occipital nerve, is a pure sensitive nerve, which is innervating the posterior part is the occipital region, and a small area near to the midline, it's and the lower part of the skull, and the posterior side is by the third occipital nerve, which is the dorsal branch of the spinal nerve C3. This is when you are revising the peripheral nervous system or when we have a lecture, so it will be much more clear for you. But this is a summarized and very important information as a slide. You have it, and it's crucial important. Of course, after the innervation, then you have to explain the blood supply. The blood supply of the scalp region, they are innervated by two main sources. One is ophthalmic artery, which is a branch of the internal carotid artery, and the other is the branch of the some branches of the external carotid artery. Regarding the branches of the ophthalmic artery from the internal carotid artery, there are again two nerves, synonym nerve with the nerve, a synonym name with the nerves. They are supratrochlear and supraorbital, that they are supplying the superior aspect of the scalp in the anterior region, mainly frontal region, that it reaches to the vertex and is communicating and anastomosing with the other arteries. The main branch or main part of the scalp here, except this frontal region, is supplied by the branches of the external carotid artery, which is a superficial temporal artery, which is one of the most important artery for the blood supply of the scalp region. Is going approximately 1 centimeter in front of the external acoustic meatus. You can feel the pulse of the external, the superficial temporal, and is almost entire or all part of the lateral aspect of the scalp is supplied by this artery. Then there are two smaller branches, which are the dorsal branch of the external carotid artery. Here, one is the posterior auricular artery, which is the smaller artery, and is supplying according to its name, the area which is posterior to the ear. So this is the posterior auricular artery. And the larger branch, which is here, is occipital artery, which is a dorsal branch of the external carotid artery and is supplying the large part of the posterior aspect of the scalp. This is the artery blood supply, and here is the same information with the other picture with some branches of this artery that we are going to discuss in the artery blood supply. And then venous drainage. Venous drainage, again, the same pattern of the artery and the same name almost. So here in the frontal region, supratrochlear, supraorbital, which is draining the frontal region, and they are draining to the ophthalmic vein, and from the ophthalmic vein they are connecting to the superior ophthalmic vein to the cavernous sinus in the brain, and inferior ophthalmic vein to the pterygoid venous plexus, which is very important. We are going to discuss it in the venous system. Then again, the larger area of the venous drainage is via the superficial temporal vein, which is draining to the very superficial vein, which is called the retromandibular vein. This vein, we mentioned it in the parotid gland, in salivary gland, that it passing through the parotid gland. So vertically it passing through the parotid gland and is located superficially. Then down it's divided to the two divisions, the posterior division and anterior division. The posterior division is draining to the external jugular vein, and anterior division is connected with the fascial vein, and they make the common fascial vein, which is finally draining to the internal jugular vein. So this is just a summarize. In the venous lecture, you will have the details of that. Then again, the same name artery, the same name vein. So posterior auricular vein, posterior to the ear, and it's, as you see, is draining to the retromandibular vein, and it draining to the external jugular vein. And the other one is the occipital vein, which is the larger one. They are making the backside, the plexus, which is called suboccipital venous plexus, which is communicating with the vertebral vein. And finally, they are draining to the internal jugular vein. So those are the venous drainage. And of course, as I talk here, that here, those areas, they are draining to the ophthalmic vein. Be careful of the danger triangle of the face that in the winter semester I lecture, and I said that is very important because here in this area there are the passage of the fascial vein and another veins that they are anastomosing together, and they don't have any valve, and the blood circulation is going up and down easily, and by the infection is going to this venous system. It can communicating in the angle of the eye. There is an angular vein which is communicating here, as you see, angular vein from the fascial vein, and it draining to the fascial vein, and the other part is communicating with the ophthalmic vein, mainly the superior ophthalmic vein, which is draining to the cavernous sinus, and it can cause the abscess in the brain, which is dangerous, or via the inferior ophthalmic vein to the pterygoid venous plexus, or via the deep fascial vein to the venous pterygoid venous plexus. So here we discussed it just to refresh your mind. And after the nerve supply and blood supply, artery and vein, then you have to say the lymphatic drainage. Of course, the posterior region, which is occipital region, they are draining to the occipital lymph nodes. They are the large lymph node in the backside. Then a small area posterior to the vertex of the ear, so is draining to the mastoid lymph node. They have different name as a retroauricular or posterior auricular lymph node or mastoid lymph node, which is finally they are draining to the deep cervical lymph node here. Then most of the temporal region, as you see, they are draining to the parotid lymph node, which is anterior to the vertex and is draining to the parotid lymph node. The parotid lymph node, we divide them to the superficial and deep one, and finally to the deep cervical lymph node. And from frontal region, some of this lymphatic drainage is going via the fascial vein and fascial vessels. they are continuing and it's leading to the submandibular lymph node. So if you have infection in frontal region, then this infection, it goes to the lymphatic drainage, and suddenly you see that you have the enlargement of the submandibular lymph node. So if the patient will come and will tell you that I have some enlargement in the backside of the head, which is occipital, so and you touch it and this occipital lymph node, they are enlarging. So I don't look for the anterior part or this or this thing. I just look the pathology in the posterior aspect of the skull to find what is the cause of the enlargement of this lymph node. So that's why it's important the lymphatic drainage of each area to be known. So this is about the scalp and the regions and innervation, blood supply, venous drainage, and lymphatic drainage. Then among all this region of the neurocranium, one specific fossa is located in the temporal region, and it's called temporal fossa. This is the depression in the side of the skull, is the place for the location of the temporalis muscle and the nerves that they are innervating it, which is the deep temporal nerve, which is we divide them to the anterior and posterior, and the same name for the artery and vein. And the clinically is very important. One is the place for attachment of masticatory muscle, which is temporalis muscle, and also there are the place for the surgical access in clinic. Border, if we want to say the border of the temporal fossa, here is the table. The superiorly, if you remember in the parietal bone, you have, and some part of the temporal bone, you have the superior temporal line and inferior temporal line. The superior temporal line is the place for attachment of the fascia of the temporalis muscle, and the inferior temporal line is the place for attachment of the temporalis muscle itself. Then the inferiorly, it's bordered laterally by the zygomatic arch, and medially, it's the infratemporal crest of the greater wing of the sphenoid bone. This is very important place, which is separating the temporal fossa from the infratemporal fossa below. So the infratemporal crest of the greater wing of a sphenoid. Anteriorly, as you see, this fossa, it's bounded by frontal process of the zygomatic bone and the zygomatic process of the frontal bone. Posteriorly is not a sharp boundary, but there is a supramastoid crest here. And medially is the neurocranial bone, which is the sphenoid greater wing, the temporal, the parietal, and the frontal, which is in this area. It was a landmark in the skull, which is the one of the thinnest part of the skull. Who knows the name here? Perfect. Therion, which is the thinnest part of the skull. Here is the landmark that if you open it inside, there is a artery which is called middle meningeal artery, which is the rupture of this artery can cause the epidural hematome that we said it in the neurocranial part is very important. And finally, the laterally is covered by is bounded by the temporal fascia that we said that is covering the skull. The content of this temporal fossa, the main content is, and the huge content of this temporal fossa is temporalis muscle. We said it in the masticatory muscle chapter. And the blood supply of the temporalis muscle is via the anterior and posterior deep temporal artery and vein, and also the superficial part of the scalp in the temporal region, as we mentioned in the previous slides. It's supplied by the superficial temporal artery and superficial temporal vein, which is draining to the retromandibular. There are three important nerves in this temporal fossa. One is, again, anterior and posterior deep temporal nerve, and the other one is the temporal branch of the fascial nerve, which is a motoric innervation for the mimic muscle and the auricular muscle in this area, and a sensitive nerve from the mandibular nerve, which is auriculotemporal nerve. There are the three nerves, and I would add another nerve here, which is a small portion of the sensitive innervation of the temporal region, is innervated by and is called zygomatico-temporal nerve, which is coming from the same name, zygomatico-temporal foramen, and is branch of zygomatic nerve. This is a slide that you had it in the masticatory muscle about the temporalis muscle. Is the strong masticatory muscle, which is originated from the temporal fossa and inferior temporal line, and is inserted to the chronoid process of the mandible that we discussed it. In this temporal region, this temporal muscle is covered by the fascia. This is called temporalis fascia. And as we said, the temporalis fascia is attaching to the superior temporal line, and is in upper part of the superior temporal line. So this fascia is single layer, so one layer. When this fascia is going down toward the zygomatic arch, is splitting to two layers. One is going anterior to the zygomatic arch, and the other going to the posterior to the zygomatic arch here in this region. So between them, it will be interfascial space that is filled by the fatty tissue and some branches of the superficial temporal vessels or artery that we are going to say, and zygomatico-temporal nerve that I said it. In this superficial region, also you have the rudimentary muscle in the human, which is the superior and anterior and superior auricular muscle for the movement of the ear, and one muscle which is for the epicranius, and it's the temporoauricular, temporoparietal muscle, which is attaching to the galea aponeurotica together with this frontalis and posterior belly of the galea aponeurotica or epicranius. Here, very nice, you can see the deep vein, deep temporal nerve and artery. They are supplying the temporalis muscle together with the middle temporal artery, which is a branch of the superficial temporal artery, which are three arteries supplying the temporalis muscle in the deep region. And here it's the details of the superficial temporal artery, which is giving the middle temporal, we said, for the blood supply, and anastomosing with the deep temporal artery. And the other one is the zygomatico-orbital, either is arising directly from the superficial temporal artery or is a branch of the middle temporal artery, which is going to this interfascial space in between the fatty tissue. And here is very nice picture, branch of the maxillary artery that is passing through the infratemporal fossa and is going to the pterygopalatine fossa here. And in the infratemporal fossa, in the brain part of the temporal region, it gives an artery which is called the middle meningeal artery, which is entering to the skull through which foramen? How many? 1, 2, 3. Yes, please. Yes, foramen spinosum is going to this. And here, remember that whenever you see the nerve which is making a loop, you see that there is a window here, and it's a nerve which is a branch of mandibular nerve, and it's called auriculotemporal nerve. Through this window or loop of the auricular temporal nerve, in any picture that you see that it passing an artery, this artery is middle meningeal artery, and this nerve is auriculotemporal nerve. And they are in the interior aspect of the temporal region that is penetrating, and it's going to do supplying the meninges that we said that the rupture is making the the epidural hematome. Here in temporal region, not only you see the fascia of the temporalis muscle, the rudimentary muscles of the auricles, and the temporoparietal muscle. Also, you can see the superficial sensitive nerve, this auriculotemporal nerve, and also the temporal branch of the facial nerve, which is reaching to this region as well. So those are the complete structures that you can find it in the temporal region, which is a specific region here in this area of the neurocranium. The other frontal, parietal, and occipital, they are not that much complicated, and we have done it in the neurocranial part. Since I'm here, so then we go to the posterior side which is the occipital region, and below the superior nuchal line, then it's the posterior cervical region and the suboccipital region. Here you can see the passage of the occipital artery, occipital vein, and the nerves that they are supplying, which is the greater occipital nerve, the dorsal branch of the C2, and the third occipital nerve, the dorsal branch of C3. And from the cervical plexus here is coming the greater auricular nerve, and also the lesser occipital nerve, which is here. So the greater auricular nerve, which is here, is going, and the lesser occipital nerve, which is here, and they are supplying the occipital region of the backside of the neurocranial region. And here, be careful of the accessory nerve, which is the cranial nerve number 11. Is supplying two muscles. One is sternocleidomastoid muscle, is going deep to that, and then when it goes into the posterior cervical region, is reaching to the trapezius muscle, and it's supplying and is innervating also the trapezius muscle. So you see that the deep passage of the accessory nerve in the lateral or posterior cervical region. Then we go to the deeper layer in the posterior cervical region, that we already said that here in this area we have a group of muscles which are called suboccipital muscle. This suboccipital muscle, they have two rectus capitis muscle, which is the rectus capitis posterior and rectus capitis posterior minor and rectus capitis posterior major, and two oblique muscle, which is called obliquus capitis superior and obliquus capitis inferior. Three of them, they are performing to the boundary of the very important triangle, which is called suboccipital triangle, and they are the superior obliquus capitis, and inferior obliquus capitis, and the rectus capitis posterior major. These three muscles, they are making this triangular space, which is called suboccipital triangle. The content of this suboccipital triangle, you can find very important artery, which is vertebral artery, and very important nerve, which is a almost pure motoric nerve for innervation of all these muscles, and it's called the suboccipital nerve, which is arising from the dorsal branch of the segment C1 of the spinal nerve. And here in this area, which is not shown, we have the suboccipital venous plexus that is communicating with the occipital vein. So this is the content of this suboccipital triangle. And here is another view of the suboccipital triangle that you can see very nice, the passage of the vertebral artery. And you know that the vertebral artery is coming from the subclavian artery and is going to the foramen of the cervical vertebra. Which foramen? First practical. Through which foramen of the cervical vertebra, the vertebral artery, they are passing. It's a long time ago, huh? Yes? Intervertebra? Transverse. Yes, transverse foramen of the vertebra, or the transverse foramen that is located in the transverse process of the C6 till C1. Be careful, the vein is passing through the C1 till C7, if you remember from the first practical. So those are the vertebral artery. And then it's going up to from C6, from the transverse foramen, here is written. Then it reaches to the C1 and is perforating the atlanto-occipital membrane, and it enters to the skull through which foramen? Vertebral artery? One, two, three, 4, 5. Final exam is closing. Today, yes? Foramen magnum, yes, it enters to the foramen magnum. They join together and they make the basilar artery, extremely important, which is one of the major blood supply of the brain, that for sure we will repeat it in the blood supply of the brain in the part of the central nervous system. It's just you need this information to understand the passage of the this artery and understand the blood supply of the region. And here is the recapitulation of the area that is supplying the sensitive innervation of the posterior aspect of the scalp and the posterior cervical region, which is greater occipital nerve, lesser occipital nerve, and great auricular nerve. So those are these two. They are from the cervical plexus, the ventral branch of the spinal nerve, and here is the dorsal branch of the spinal nerve, together with the third occipital nerve, which is here is not mentioned, and it's the area for the here the dorsal branch of the segment C3. So those are the neurocranial part, scalp, blood supply, innervation. So any question about this area, you have to say, remember of the scalp, that it can help you, your 5 layer of the scalp, and then you start to the saying about the nerve and blood supply and so on and so on. One of the important, we go into the region of the splanchno-cranium or face region. One of the important region in the splanchno-cranium or the face part of the head is this area, which is called parotido-masseteric region. According to this name, it must be the region that is located, the parotid gland, and the location of the masseter muscle. So that's why it's called parotido-masseteric region. Immediately when you say about the region or triangle or anything, you have to say the boundary to understand where is it. You cannot say that it is here somewhere, yes? Because when you are reporting some pathology in the face region, so you have to say this pathology, this tumor, this, infection is in the parotido-masseteric region, or it is in the buccal region, or it is in the infraorbital region, or if it is this one. So the doctor will focus on that region that you mentioned it. Instead of that, there is some pathology in the head region or in the head region, yes. So boundaries superiorly is bounded by the zygomatic arch. Inferiorly is the mandible, mainly the region of the angle of the mandible and posterior part of the body of the mandible. Anteriorly, where is finishing the masseter? So it means the anterior border of the masseter. Posteriorly is not the sharp border, but is the imaginary line which is coming from the tragus and is going down posterior to the ramus of the mandible, and it reaches into the angle of the mandible. So this area is called parotideo-masseteric region. Yes? And when you go to the dissection and you get the tusk, there is a cadaver, fresh cadaver, and there is a tusk that you have to dissect the parotideo-masseteric region. Yes? What is the first layer here? You have the scalpel, you have the pincet, and you have a knowledge of anatomy. So what is the first layer in this region? Yes? A skin. So you cut the skin. This skin, of course, is a little bit filled by, or there are some small hairs that they are called pili, and especially in men, there are the thicker hair which is called barbe or barba. So you cut the skin. After the skin is what? Yes. What? Still no. Under the skin is subcutaneous connective tissue. Yes. So there are the fatty tissues. So layer by layer, subcutaneous connective tissue. That you remove it, subcutaneous connective tissue, and then you reach to the the fascia, which is covering the parotid gland and masseter muscle, which is the parotideo-masseteric fascia. When we talked about the skin, immediately we will ask you this part of the skin that is located in the parotideo-masseteric region. If somebody touch, you will feel it, yes? Which nerve is innervating the sensitive innervation of this region? There are two nerves. One is this nerve, which is called the great auricular nerve from the cervical plexus, is innervating the inferior part of the parotideo-masseteric region, and the other nerve, which is, we said it here, together with the superficial temporal vessels is going, it is this way, this nerve, and it's called auriculotemporal nerve branch of mandibular. So these two nerves, they are supplying the parotideo-masseteric region, the sensitive innervation, yes? Then, after that, under the skin and before the fascia, so you have some mimic muscle in the layer of the subcutaneous connective tissue, and you have to remove this mimic muscle to reach to the fascia, which is covering the power. What are the mimic muscle here? We discussed it. They are mainly the major zygomatic and risorius. You see, the risorius is coming, the zygomatic bone, zygomatic major, and the small or some portion of the platysma that is coming from the neck region to the above the mandible. So those are the mimic muscle. When you remove it, then you reach to the parotideo-masseteric fascia, which is covering the parotid gland and masseter muscle. And this fascia is, we said it in the parotid gland, this slide, and this fascia is coming from the zygomatic arch, is going to the mandible, and it continues to the neck region as a investment cervical fascia that today we are going to discuss. Is a little bit difficult to understand it, but I prepared the table for you. And it's continued to the neck region. This fascia, parotideo-masseteric fascia, at the lesion of the mandibular angle, it's making a thickness which is called angular tract. And this angular tract is separating the submandibular region from the parotideo-masseteric region. So that's why it's very important tools for the stopping of the spreading of infection from parotid to the submandibular or vice versa. Then in the region of the parotideo-masseteric region, after you cut off the fascia, you will reach to the surface of the parotid gland and surface of the masseter. Yes? You know that through the parotid gland is coming the parotid duct. We said it in the chapter of the salivary gland, that this parotid duct is going over the masseter muscle, is piercing which muscle? Yes? Buccinator muscle, and is open to the oral vestibule, opposite to the upper second molar in the vestibule. In the passage of the duct, so you can see some small accessory parotid gland, which is variable. And the projection, if you want to find the parotid duct, the projection that is helping you in dissection room is if you make a line from the philtrum, which is here, to the notch, which is between the two tragus, is called intertragus notch or incisura. So this line, if you connect this line is passing through the passage of the parotid duct. So you can, by the help of this line, because you see the skin, so when you cut, so where you can find this parotid duct, which is the item of the, for example, question in the dissection exam. So this is one. Or there is a line which is connecting the corner of the nasal wing to the inferior part of the auricle. So this is also passing through the place that is passing the parotid duct. Then we reach to the parotid gland, and we also discussed it in the salivary gland lecture, but here is extremely important. There are some relation between the parotid gland and some structure that they are passing through that. Three of them is very important. The most superficial one is retromandibular vein. The retromandibular vein is passing superficially through the parotid gland, is formed by the junction of the retromandibular vein, is passing through the parotid gland, and is formed by the junction of the superficial temporal vein and the maxillary vein. Is going inside the parotid gland and is divided to two divisions, the posterior division and anterior division. The posterior division is draining to the external jugular vein, and anterior division is going to the fascial vein. Together they make the common fascial vein, and it draining to the internal jugular vein. That we are going to discuss it in the chapter of the vein. After the vein, you know very important nerve that it passed through the parotid gland and is, yes, fascial nerve. This is extremely important that it is coming out from the skull through which foramen? 1. Oh my God, 2, 3, 4, 5. My God. Yes? Any more? Yes, please. Stylomastoid foramen is coming through the fascial canal through the stylomastoid foramen, and is, after a few branch, it enters to the parotid gland. And when it enters to the parotid gland, is making a parotid plexus, and through this parotid plexus, it gives 5 branches here. There are temporal, zygomatic, buccal, marginal mandibular, and the cervical branch for the motoric innervation of the mimic muscle and platysma, cervical one. Then, after that, the deep structure that it passed through the parotid gland is external carotid artery. External carotid artery inside the parotid gland, it gives one of the dorsal branch, which is posterior auricular artery. We mentioned it. Sometimes the occipital artery is coming in the small course. Then, but important is that the external carotid artery inside the parotid gland is divided to 2 terminal branch. One is maxillary artery, and the other is superficial temporal artery that is coming out from the parotid gland together with the superficial temporal vein, and one nerve here. Which nerve? We said it till now 4 times. Yes? No? Yes? Auriculotemporal nerve, which is not drawing here, is branch of mandibular nerve. So 3 structure, 1 centimeter in front of the external acoustic meatus. Here you have to dissect it in the dissection course also. So remember, these 3 structures that they are passing in the cross section of the parotid gland, you can see the retromandibular, the fascial nerve, and external carotid artery. So those are the structure that showing the retromandibular vein here. This is the retromandibular nerve with the posterior division and anterior division. Here is very nice. Posterior division, anterior division together with the fascial vein. There are common fascial vein draining to the internal jugular vein and posterior division to the external jugular vein. This is the place that the fascial nerve is coming from the stylomastoid artery, foramen. It giving a several branch like a posterior auricular, branch for the posterior belly of digastric, branch for the stylohyoid muscle, and it enter to the parotid gland here and is dividing the parotid gland to the thicker superficial part and deeper, thinner part. So parotid plexus of the fascial nerve inside the parotid gland, dividing the gland to the superficial part and deep part. Why is important clinically? If the patient has some pathology in the parotid gland, if this pathology is in the superficial of the gland, you can remove this tumor or pathology from the superficial part without touching the fascial nerve. If this pathology is penetrating to the deeper part, then you have to inform before operation that you might or most probably you will lose some branch of the fascial nerve because it's impossible to remove without damaging of this nerve, and the people, they are losing the motoric innervation of the mimic muscle. So the patient must be informed, and he will not appreciate that you saved his life, but he will sue you that why is not working my mimic muscle. Yes. So that's why you have to explain these things before the operation, that he might lose the mimic muscle. So this is important for you, the clinic. And here you can see the fascial nerve, and is divided to the 5 branches that we mentioned it. And in the chapter of the peripheral nervous system, again, definitely we are dividing. Remember, if you put your hand on the lateral aspect, so the finger is showing the passage of the branches of the fascial nerve, the temporal, zygomatic, buccal, marginal, mandibular, and cervical, that during the dissection course, when you open the parotidomasseteric fascia, when you reach to the parotid gland, so you will see these branches that are coming, and they are very thin. Be careful not to cut them. And the deepest structure, as we mentioned it, it's the superficial temporal external carotid artery, which is inside it, giving the maxillary artery and superficial temporal artery together. And this superficial temporal artery, it gives very important branch inside the parotid gland, which is here, and it's called transverse fascial artery. This is also the artery which is passing through the parotid gland below the zygomatic arch here outside. So this is the cross section for the recapitulation. Very nice picture that you can see the skin, the subcutaneous connective tissue, the fascia, and parotid gland. And here is the retromandibular vein. Here is the external carotid artery with the sympathetic nervous plexus. And here is the nerve, fascial nerve, and some lymph node, the superficial and deep lymph node, and how the parotid duct is going out, is going over masseter muscle, and is piercing the buccinator muscle, and is open opposite to the upper second molar in the oral vestibule. Very nice cross section. And when you remove whole gland, then there is a place which are some muscles, and they are called the styloid septum, which is coming from the styloid process, is as a stylohyoid muscle and the stylopharyngeus muscle. In a while we are going to discuss. And here is posterior belly of digastric muscle. And here the deepest part of the parotid gland is interrupted between the mastoid process and neck of the mandible. That's why the people that they have mumps, the virus mumps, is making the enlargement of the parotid gland and is extremely painful. because by the movement of the jaw, so this mandible is pushing the gland toward the mastoid process and is making extreme pain. I don't know if you have experienced the mumps, anybody? So he knows that it's very painful disease of the parotid gland. Here, the viral infection in this area, which is usually the child's, they get it. So this is the parotidomasseteric region. Then we have another region of the face or splanchocranium, which is buccal region. Again, when we say is, you have to say about the borders. The buccal region borders, of course, is the region that is in front of the parotidomasseteric region. So here was parotidomasseteric region, and here it's the buccal region. Superiorly, the buccal region is bordered by the infraorbital margin. Inferiorly is bordered by the body of the mandible, inferior margin of the corpus mandibular or body of the margin. Anteriorly is bounded by the nasolabial sulcus and the labiomarginal sulcus, which is separating the buccal region from the oral region. And this buccal region is palpable from outside. You can examine it from outside, and also you can put your finger and palpate it from intraoral side. Yes, so it's the examination that you can do it outside and inside. If you want to dissect the buccal region, you have to dissect 7 layers. First layer, skin, covered by the fine hairs, which is called pili, or in men, it's a little bit thicker, which is called barba. It's the hair that you have it like a bird. Under the skin, you have subcutaneous connective tissue, which are some fatty tissue and some glands, sweat glands, they are located, and some hair follicles. Third layer, immediately when you have it in the face region, you have mimic muscle. You know that mimic muscles, they are subcutaneously located, yes? And in this buccal region, you have to know which mimic muscle you find it, and then we will see. After the mimic muscle, the superficial mimic muscle, we have one space here between the superficial mimic muscle and the buccinator muscle, which is making a deep muscle layer, which is 5th layer. And this is called intermuscular space. And finally, the 6th layer is the submucosal layer, and after that is mucous membrane in the inside of the cheek is mucous membrane. In submucosal connective tissue, you can find the minor salivary gland, which is called buccal gland. Third layer, after the skin, subcutaneous connective tissue, we had the mimic muscle in the buccal region. Those are part of the orbicularis oris, part of the zygomatic major and zygomatic minor, part of the risorius, levator labii superioris, levator labii superioris aloequa nasi, levator angulis oris, which is under that, depressor anguli oris, and platysma. Those are the mimic muscles that they are located in the third layer of the buccal region. After that is 4th layer, which is called intermuscular space. It means between this mimic muscle and the buccinator. Here, what you can find the fascial artery and fascial vein. You can find the buccal branch of the mandibular nerve and buccal branch of the fascial nerve, that we said that from the parotid plexus, one of the 5 branch, it's coming. So the buccal branch of the mandibular nerve sometimes is called long buccal nerve, and it's going together with the buccal artery and buccal vein. So facial artery and vein, buccal nerve, branch of the mandibular nerve, buccal artery and vein also, buccal branch of the facial nerve, which is here, you don't see it because the mimic muscle is already gone, and parotid duct, which is piercing the buccinator muscle, and buccal fat pad. There is a corpus adiposum buccae, which is, I will show you in a while. And here is the picture of the buccal region here with the facial vessels, and here now you can see the buccal branch of the facial nerve that is going and is reaching to the buccal region and is innervating the mimic muscle in this area, the motoric innervation from the fascia. Here is a passage of parotid duct over masseter. This is parotidomasseteric, and here it enters to the buccal region, which is piercing the buccinator muscle, and here is the anterior aspect. So all these vessels, nerves, and important structure, you can find it in the 4th layer between the layer of superficial mimic muscle and the deep layer, which is buccinator. Yes? So in this space, which is called intermuscular space, you will see this structure. Now then, after removing of this part, then you reach to the buccinator muscle. That this is a slide that we had a lecture about the mimic muscle. It's the only mimic muscle that it has a fascia, which is called buccopharyngeal fascia, and is pierced by the parotid duct. And here, then, in this intermuscular space, there is a corpus adiposum buccae, or buccal fat pad, or Bichat's fat pad. Is according to the name of the person that who find this one first time, is called Bichat. This is the size of this buccal fat pad, that which is between the masseter muscle and the buccinator muscle, is filling the empty space and is protecting the structure, is very important for the aesthetic point of view. And also it has the function for the sucking of the milk by the infant, for example, helping to make the function of masseter and buccinator and protecting them. As you see, the parotid duct is crossing the buccal fat pad also. And this buccal fat pad, if it's extended beyond the masseter muscle, especially in children, so they make the chubby cheek cute. You can take it and play with that. It's very cute, and it's chubby face. You have it, yes. So it's making a cute face of the baby because the buccal fat pad, they are very big in this place for the newborn and for the children. Is not related to the nutrition, is very huge, and is going over masseter muscle, so that's why they have a bulky, cutie, fullness face. But there is a problem for some person that they don't like to have a chubby face like this, and if this buccal fat pad is coming from the buccinator to overcoming to the masseter, so they have a chubby face and somebody doesn't like, so they go for the operation, and usually in the molar region we cut it, we remove this buccal fat pad, which is approximately in the size of the golf ball, and then after the operation you can have the like a face a little bit maybe better than the chubby face or the fatty face that you have it here. Yes. So this is just for your information. Another information clinically is that the buccal place or buccal space or buccal region is the space that is one of the region that the infection, it can goes via the root of the tooth toward this space, as you see for this patient. It's making a dumbbell shape or part of the face. And this one happened that if the root of the tooth is beyond the attachment of the buccinator muscle. So this is a buccinator muscle attaching to the alveolar process of the molar region here. And if the root is going beyond that, so the infection from the root is accumulating in the buccal space, and here is making a abscess, which is again can be dangerous, that through the fascial vein and pterygoid venous plexus, it's going to the sinus cavernosus or cavernous sinus via the emissary vein, mainly through the foramen ovale, and it can cause the brain abscess. Or buccal region also is communicating to the temporal fossa, because between the interfacial space there is a fat tissue that is continue to the buccal region as a corpus adiposum buccal, and also is communicating with the infratemporal fossa. So the buccal region is communicating to the intracranially, and it communicating with the temporal and infratemporal fossa. Mental region is a small region here in the splanchocranium, or the face part of the head. This is the place that your chin is located. And again, when you got this region, very simply you have to describe the boundary. The boundary superiorly is made by this sulcus or groove, which is called mentolabial groove. The mentolabial groove is separating the oral region from the chin region. So mentolabial groove. Lower border is made by the base of the mandible or the chin part of the mandible, and laterally in both sides is separated from the buccal region. So anterior extension down of the buccal region, one is oral region that we described it before in the lecture, and here is the mental region. What you have, mental region, the skin is strong and in male with the hair barbe. Some muscles here, that mentalis muscle, mimic muscle, depressor labii inferioris and depressor anguli oris. In a while I will show you. Mandible skeleton, the blood supply, mental artery and mental vein, lymphatic drainage to the submental lymph node, and innervation, mimic muscle by the facial nerve, sensory innervation by mental nerve. Do you know the mental nerve is coming from which foramen? Of course, is mental foramen. But this foramen is the continuation of which canal? Yes? Mandibular canal, which the inferior alveolar nerve and artery and vein, they are passing. So as a matter of fact, this mental nerve is the terminal branch of the inferior alveolar nerve. And here you have. So those are the muscle, the depressor anguli oris, the depressor labii inferioris, and deeper part, the mentalis muscle in the mental region. Here is the mental foramen, which is located below the apex of the second premolar for the dentistry. Be careful, here you apply anesthesia. And here you can see the exit of the mental nerve, mental artery and mental vein, and they are the terminal branch of the inferior alveolar nerve, artery and vein, and this is the pressure point for the examination of the third branch of the trigeminal nerve, which is mandibular nerve. And here you can see how the nerve is passing, and here is showing that this inferior alveolar nerve that is entered to the mandibular foramen and it passing through the canal, it exits from this mental foramen as a mental nerve together with the artery and vein, extremely important. And don't forget that is the area for the injection of the anesthesia if you want to work from the incisor approximately to the second premolar, anything that you want to do it. So by the injection to the mental foramen, which is, as you see, is below or the root or the below and between the root of the second premolar and first premolar, you inject it here and you do the numbness of this area. Next region that we are going to discuss is infraorbital region. Infraorbital region is anatomically important area of the face, which is, according to its name, is below the orbital region, so, and above the upper lip. This is a small area which is bounded by the orbital region, by the nasolabial groove or sulcus, laterally by the zygomatic region, and inferiorly by buccal region. So this is the infraorbital region. The skin in this area is thin, subcutaneous connective tissue, and then mimic muscle. This area, it has levator labii superioris, levator labii superioris alaequa nasi, zygomatic major, minor, and some part of the orbicularis oculi that in a while I will show you. Sclot is making the anterior surface of the maxilla, which is here in this region you have the infraorbital foramen. And artery blood supply here, they are passing the fascial artery, transverse fascial artery, which is branch of superficial temporal artery, and infraorbital artery, the most important one. Vein, the same. Lymphatic drainage to the submandibular lymph node, and again, motoric innervation, fascial definitely, and sensory infraorbital nerve, which is a branch of the maxillary nerve and is a pressure point for the examination of the second branch of the trigeminal maxillary. So here, which is infraorbital foramen and is covered by the levator labii superioris muscle. So the infraorbital foramen is covered by this muscle. And here you can see the exit of infraorbital nerve, infraorbital artery, and infraorbital vein. And here is the proximity of to this foramen. It passed the fascial vein and fascial artery. And here also is the view from the anterior side, is the area of the infraorbital region. We said that this region is the palpatory examination of the second branch of the trigeminal maxillary, very important. The examination of the first branch of trigeminal palpatory is which foramen? Mental for the third branch, mandibular. Infraorbital, mental for the third branch, mandibular, infraorbital for the second branch, and yes, supraorbital foramen for the first branch for the palpatory exam. Almost they are in one line. We said it in the previous semester lecture. And again, don't forget about the importance of the infraorbital foramen, because it's the place for the injection of anesthesia to this place. And if you inject the anesthesia for the infraorbital foramen, this bluish part that you see, it will be numbed. So you can do anything in the upper teeth, approximately from the incisor to the mesial part of the first molar. You can do any surgery or any procedure, surgical intervention that you wanted in this area. So it's a place for the injection of anesthesia for the larger vehicle. Then we have the zygomatic region. Is a small region which is from lateral to the orbital region and lateral to the infraorbital region. It's very important region for the aesthetic and appearance of the place of the human, and the place for the muscle attachment. You know that which masticatory muscle is attaching to the zygomatic arch? Yes. Two. Which masticatory muscle attaching to the, or originated from zygomatic arch? Four, five, six. Yes, please. Masseter muscle, yes. So, and also it's the place for attachment of the mimic muscle, zygomatic major, zygomatic minor, masseter, we said, originated, here is written, zygomatic arch. Skeleton is zygomatic bone that we mentioned, that it has three, is a acute bone. It has a three surface, three process, and three foramens. We mentioned it in the splachocranium part. The vascular supply is zygomatico-orbital from superficial temporal, transverse fascial from the superficial temporal, and the vein is the same. Innervation, as usual, since you have mimic muscle, is innervated by fascial nerve, and sensory innervation, the zygomatico-fascial from outside, and zygomatico-temporal, that is supplying the part of the temporal region. Here you can see the zygomatico-fascial nerve that is coming out from the zygomatico-fascial foramen. Behind, in the temporal surface, is the zygomatico-temporal, which is supplying the temporal region, a small region in the temporal area. Yes, so this is the neurocranial part, the head region, the splachocranial part, the face region, the deep region, infratemporal, pterygopalatine, you have it the other lecture, the material, and in a while we will have the very important and very complicated region, which is parapharyngeal space or lateral pharyngeal space and retropharyngeal space. Break? I know. So we continue the next chapter for the today's lecture. Parapharyngeal, or English terminology they use it, lateral pharyngeal and retropharyngeal spaces. Those spaces, they are a little bit more complicated. So I hope you are after break, you are more fresh, and somehow we have to manage it to understand it. First of all, where is the parapharyngeal space? Para, it means parallel, and pharynx is pharynx. So the spaces that they are parallel with the pharynx, they are located, and they are laterally to the pharynx. So that's why they call it parapharyngeal or lateral pharyngeal space. And as a matter of fact, is the medial, the most medial continuation of the infratemporal fossa on the lateral surface of the pharynx is the parapharyngeal space. This parapharyngeal space, they are the potential space that they are filled by the soft or loose connective tissue, some blood vessels, and some nerves that they are located here in this region. And we are going to discuss it. So what is the shape of this, parapharyngeal space or lateral pharyngeal space? Is the inverted pyramid. So it means that the cranially or the superiorly, the base is going toward the base of the skull, and the apex of this inverted pyramid is going toward the hyoid bone, which is respectively the greater horn of the hyoid bone. So this is the location, and clinically is very important because this parapharyngeal space is the potential space for the formation of the tumors or abscess in this area, and because they are deep region, you don't see it in the beginning. And when it's growing and growing and is making a life dangerous state of the patient, then we negotiate it. So it's very dangerous area. That is a deep area. And with the knowledge of anatomy, you can prevent the spread of infection in this area and tumor to the farther region, for example, the mediastinum, which is in the thorax, and it can be fatal consequence. We have a patient that they died because of the tooth infection simply, to the parapharyngeal space, and parapharyngeal space down to the mediastinum and finish. So that's why it's important, this area. So there is not a sharp boundary or exact boundary for the parapharyngeal space, but this is, I think, it's the summary and extraction of the different literature that I have found, and its logic boundary for this parapharyngeal space, the inverted pyramid. Superiorly, we said that is the base of the skull, mainly the bones of the sphenoid, temporal, and occipital bone. And this area, they are the area that is open, the jugular foramen, carotid canal, hypoglossal canal, and foramen lacerum. Medial, it's the pharyngeal wall. We said that lateral pharyngeal space is the lateral wall of the pharynx. So medial border is the pharyngeal wall, which is covered by the pharyngobasilar fascia. Anteriorly is the pterygomandibular raphe. Is not a sharp border, but also a medial pterygoid muscle also is making a border for anterior side. Posteriorly is bounded by perivertebral fascia, is one of the deepest layer of the deep cervical fascia that we are going to discuss it. And this fascia is covering the longus colli and the capitis muscles, and also is enclosing the scalene muscles, but not enclosing the sternocleidomastoid, but the sternocleidomastoid is making also a posterior boundary for the parapharyngeal space. The laterally is much more, structure is involved like a ramus of the mandible, deep lobe of the parotid gland, medial pterygoid muscles. Those are the main boundary for the lateral side. And inferiorly, as we said, is the greater horn of the hyoid bone, where the posterior belly of digastric it continue as an intermediate tendon to the anterior belly of digastric. And this is a most beautiful cross section of the parapharyngeal space through the transverse section through the level of C2, C3. If somebody understands this cross section, so it means that he understands the parapharyngeal space. To simplify it, what structure that we can find it in this cross section, so I recommend you, first of all, don't afraid, of course. Second of all, use your knowledge that till now you have it. If I get this cross-section, that the same cross-section, you can get it in CT scan or in the MRI or in the radiological scans. So what I would find, I would find this very hard tissue, which is mandible. Yes? This is the mandible, and I know that in the outer surface of the mandible, in the angle of the mandible, we have a muscle which is, yes? Masseter muscle, yes? So here I have mandible, in the angle of the mandible, it was the tuberositas masseterica or masseteric tuberosity is the insertion of masseter, so his huge muscle is masseter. Inner side of the mandible, in the angle of the mandible, we have another muscle, which is, yes, medial pterygoid muscle, which is attaching to the pterygoid tuberosity in the angle of the mandible in the medial side. Yes? Okay. So mandible, masseter, medial pterygoid. There is a space that in the detail we are going to discuss and extremely important, especially for dentistry student. If somebody get this question and doesn't say it's the area or is the space that whole life you will inject anesthesia here. Yes. This space between the inner surface of the mandible, ramus of the mandible, and the lateral surface of the medial pterygoid muscle, this space is called pterygomandibular space. Is the medial pterygoid between the medial pterygoid and inner surface of the mandible. What is the content of this? We already somehow mentioned it. Is inferior alveolar nerve, inferior alveolar artery, and also here is missing inferior alveolar vein. This is a place for injection. Any dentist that he want to do any work in your lower jaw, in the posterior side or whole jaw, half a jaw, so he will inject here. Somehow from the oral cavity, the needle must go in the narrow space here, and it will be ended here, and he inject the anesthesia here. So he will do the numbness of inferior alveolar nerve. Yes? So the content of the pterygomandibular space is inferior alveolar nerve and vessels. A little bit in front of that, there is another nerve, which is lingual nerve, branch of, both of them, they are branch of mandibular nerve, the third branch of trigeminal. So this is the most important content of the pterygomandibular space, all right? Posterior to the mandible, what you have? Outside and posterior, and it's turning inside. There is a gland. What gland you have? Yes? Yes? Parotid gland. So if I find the mandible, and here is the ramus, and here is the angle, so here is posteriorly is the parotid gland that we already said the details. And if you remember, inside the parotid gland, here maybe you could see that, but here, inside the parotid gland in the superficial part, it passed one vein. What vein it passed? Right now I said it maybe 5 times. Yes? Auriculotemporal nerve is not exist. Vein is not exist. Six times I said it. What structure passed through the parotid gland? 3 main structure. Maybe you remember the most important, which is facial vein, facial nerve. Then it was 1 vein and 1 artery. Yes. Retromandibular vein. So this is retromandibular vein. It passed through the parotid gland. What artery it passed through the parotid gland? 7 times I said it. Yes? What artery? Yes. Posterior auricular is branch of that artery that it passed. Of course, you are true. It is true. But it's the main artery. External carotid, here I have external carotid artery. If I go a little bit, the cross section higher, so this external carotid artery in different literature, if you see that this external carotid artery is inside the gland, also is correct. Yes? So it depends on which level you do the cross section. So this artery, which is external carotid artery, also is inside the gland. Here is missing which nerve? Facial nerve, also it passing through the parotid gland, dividing the parotid gland to the superficial and deep. What does it pass from the parotid gland out, going over the masseter, is piercing the buccinator muscle and is open to the oral vestibule, opposite to the upper second molar is, yes, parotid duct. So here is parotid duct. So it means that, again, I confirm that this is the masseter muscle and this is the buccinator. Yes? Here is buccal region. So if it was the parotido-masseteric region here, so here anteriorly is buccal region. So it means that the skin, subcutaneous connective tissue, mimic muscle, buccinator muscle, intermuscular space, and in intermuscular space, what vessels you find? Yes, facial artery, facial vein I have here. Yes, so you will use this theory that we said, now you are applying to this cross section, and it make it easy to understand. Then I go further, and here I have inside the oral cavity. I look at inside the oral cavity in the lateral side of the pharynx. This is the superior constrictor muscle of the pharynx. And here you have the, yes, palatine tonsil. There is a palatine fossa which is inside the palatine tonsil, one of the valvular ring that you had it in the oral interview. And this palatine tonsil is bounded by two muscle or two arch. The anterior arch or muscle is, yes, palatogluteus, perfect, and posterior one, yes, palatopharyngeal, perfect. So between these two arch there is a palatine tonsil. Is the patients come to you and say, you will see this palatine or a palatine tonsil. Okay? Now, where is the parapharyngeal space? Parapharyngeal space, this is the raphe which is connecting the buccinator muscle with the superior constrictor muscle of the pharynx. This is called pterygomandibular raphe or buccopharyngeal raphe. Yes, this is anterior. Parapharyngeal space, be careful, is here, 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 all this space. It's difficult, yes? To be a little bit easy, we divide all this space which is called parapharyngeal or lateral pharyngeal. If you find the pharynx, which is here, and lateral to that is the lateral pharyngeal space, yes? Or parapharyngeal space. To be easy, there are some group of muscles from posterior and lateral. They are coming anterior or inferior, and superior and lateral. They are coming inferior and medial. And this group of muscles, they are called styloid septum. Oh my God. What are those muscles? The most lateral part is, biggest muscle is sternocleidomastoid. Then posterior belly of digastric muscle. Then there are three muscles that they are originated from styloid process. So here you have a styloid process. So the most laterally, stylohyoid. Then in the middle, styloglossus. Then the most medial, which is close to the wall of the pharynx, is stylopharyngeus muscle. These muscles, except the sternocleidomastoid, here they have the common fascia that they are enclosing this fascia, these muscles. So that's why they call it a styloid septum. And this group of muscle is dividing the parapharyngeal space to anterior to this septum, which is called it means anterior. Styloid, it means a styloid septum, space. Peristyloid, space, it means all the space which is in front of that. Never go behind. Here is called peristyloid part of the parapharyngeal space. Yes? What is behind here of this styloid is called retrostyloid part of the parapharyngeal space. Yes? Clear till now? Clear? If I ask you, what is the content of peristyloid part of parapharyngeal space? Deep part of parotid gland. Inside, retromandibular, facial nerve, external carotid artery. Here, there is one artery, which is a branch of facial artery, and is supplying the palatine tonsil. What is this artery? Yes. Perfect. Ascending palatine artery. Content of peristyloid part of the parapharyngeal space. Question in PC test. What is the content of the peristyloid part of the parapharyngeal space? A, B, C, D. Yes, all of them. Here, a part of the parapharyngeal space, please pay attention, which is nearby palatine tonsil. It means here, this area. Yes? Is parallel with the palatine tonsil. This part of the peristyloid part of the parapharyngeal space is called paratonsillar space. Paratonsillar space, the space that is parallel or parallel to the pharyngeal, to the palatine tonsil. Extremely important space, two reasons. One, spread of infection. You know that tonsillitis is a common infection that the patient have. Palatine tonsil infection is dangerous. If you don't treat it, it goes to paratonsillar, space of the parapharyngeal space. Then it goes all this area. Then under this styloid septum, it goes to the retrostyloid part. From the retrostyloid part, it goes to the behind of the pharynx, which is called retropharyngeal part. Then when it goes behind the pharynx, it's the highway from Prague to Brno. It's going down to the mediastinum, which are heart, lung, boom, patient will die. There is nothing here, according to the gravitation, to stop the spread of infection. When it reaches behind the pharynx, there is a loose connective tissue and nothing to stop it. Gravitation is infection going very fast to the mediastinum, and it's killing the patient. Now, what is the retrostyloid part of the parapharyngeal space? What is the content? I don't know if we said it several times, but we're repeating, this is a crucial important. The first content of the parapharyngeal space is the content of the carotid sheath. Who knows what is the content of the carotid sheath? This is a question that if you don't say it in oral examination, immediately you fail, without any excuse. Laterally, internal jugular vein. Medially, common or internal carotid artery. It depends on which level you cut it. If it is lower level, it's common carotid. If it is upper level, it is internal carotid artery. Never external carotid artery in the carotid sheath. Between these two vessels, posteriorly is which nerve? Vagus nerve. Between these two vessels, anteriorly is a branch of the hypoglossal nerve, is the deep ansa cervicalis, which is making the innervation of infrahyoid muscle, the most of them. Two nerve is remaining, one nerve here, which is more laterally and is innervating the sternocleidomastoid, which is, yes, accessory. One nerve which is most medially toward this muscle, which is a stylopharyngeus muscle, is the only exception that is innervated by, yes, glossopharyngeal nerve. Finish the content of the retrostyloid process, part of the parapharyngeal space, except this artery, which is parallel with the wall of the pharynx, and is branch of external carotid artery, is a medial branch of the external carotid artery, which is called, yes, ascending pharyngeal artery. Be careful, common mistake of a student. In peristyloid part, ascending palatine artery here. In retrostyloid part, ascending pharyngeal artery. I didn't say another importance of this parapharyngeal space. You know, you have heard some of your family, they are going under operation of the palatine tonsil. It's called tonsillectomy. It's very infected, that is very infected. They have to remove it. Yes, it's a simple operation, but there is a case that the people, they died because of bleeding after operation. Why? The surgeon must absolutely be careful of tonsillar branch of the ascending palatine artery, because if it is to start to bleed, very difficult to stop. Two clinical important: spread of infection, bleeding, paratonsillar space. Yes? So this is the content of the retrostyloid part of the parapharyngeal space. And then behind the pharynx, here there is an area which is in detail, we are going to say it in the next slide, is retropharyngeal space. If you explain this diagram and to understand this diagram, then everything is clear for you. Yes? In some slide, I will show you some details of that, but you need it in the future, especially dentistry for the future in a state exam. But this information is the basic information that you have to know. Yes? So in this case, with this picture, you can explain that if you have some tooth infection, third molar here, it can go to the pterygomandibular space. It can go to the parotidomasceteric region. It can go to the peristyloid part of the parapharyngeal. It can go to the retrostyloid part. It can go to the retropharyngeal. It's going down to the mediastinum. Boom. Yes? This is the explanation that we said. The styloid septum is the fibromuscular septum that is with these muscles together with one ligament, a stylohyoid ligament. They are separating peristyloid from the retrostyloid. Those are after the fascia, removing of the common fascia, those are the muscles. And here the passage of the external carotid artery, which is going between the stylohyoid and the styloglossus muscle. This is the details. And arteria palatina ascendens is between the styloglossus and the stylopharyngeus. You don't need it that much to do. We said that peristyloid space and retrostyloid space, what are the place? And we explained the place that you have it. We explained the retrostyloid part is the place that is containing the carotid sheath and the content together with the additional nerves and the ascending pharyngeal part. We already explained. Clinically is important that, for example, if there is a tumor in the parapharyngeal space here, for example, mainly the tumor of the parotid gland, if it is enlarging, in superior and in the lateral and in the medial and in the lateral part, there are the bony landmarks, so the tumor will not expand. But where does it grow, this tumor? Toward the medial side. So this tumor of the parotid gland, if it grow, it's going to the medial side, it's pushing the medial side, and it's going to the tonsillar region. Patient will come and say, I have something in my throat. Because it's a deep space, you don't see it under the skin. Yes? Later you understand there is something wrong. And patient will come, he will say, and you will see some mass is pushing the ovula, which must be in the center here. The ovula is shifting to the other side. Something is shifting it. And there is a mass here. Two possibilities, abscess or tumor. Yes? Ovula, there is a mass here. Yes? So something from inside is pushing there. So this is the important, or it going inferior. This is the cyst. In parapharyngeal space, you can see that it's shifting the retrostyloid part, the internal carotid artery and the internal jugular vein. Here is the tumor of the gland, parotid gland in parapharyngeal space. This is the tumor in parapharyngeal space, tumor of the parotid gland. Here you can see a mass of the tumor. Here is the operation of that tumor. This is the removing of that tumor. This is the patient after the healing. You saved the life. Pterygomandibular space, extremely important space, I already described it, is the space between medial pterygoid muscle and the internal surface of the ramus and angle of the mandible. This space is called pterygomandibular space. So dorsally is by the parotid gland is bordered. Cranially by the lateral pterygoid muscle, horizontally is placing, anteriorly is the pterygomandibular raphe. The content, inferior alveolar nerve artery vein. A little bit more in front is lingual nerve and sphenomandibular ligament. There are some fatty tissue and some literature that also they write the chorda tympani, which is joining to the lingual nerve. We said is the place of the application of anesthesia to the pterygomandibular space. Yes? And this picture is very nice picture and is explaining you the dorsal border of the pterygomandibular space, which is what? Which is what? Parotid gland. What is inside the parotid gland? 8 times now. What? Retromandibular vein, external carotid artery, and facial nerve. Yes? You go to the dentist, he wants to fix your teeth, he will put the injection. He must go here, yes, to do the inferior alveolar nerve block. Yes? Yes? He go more. He go more. He go more. He enter to the parotid gland. Because you don't see. You have to feel it where the needle it is. So we have a technique that we teach the student. But if the doctor will not pay attention, the needle, it goes to the parotid gland behind. You see? He will inject. What will happen? Yes? Paralyzing of the facial nerve. Because the injection, it went instead of inferior alveolar nerve to the facial nerve. And patient will lose all the mimic muscle in one side. It's extremely scary. It's like that the patient got a stroke, brain stroke. Yeah. Fortunately, it's reversible. You have to wait 4 hours, then he will go back, the effect of anesthesia go, but it's a mistake of technique of anesthesia. So here you can see the inferior alveolar nerve, which is going to the canal, and in front of that is lingual nerve, which is going here. This is the direction of the needle to this space, and this is the superior border, which is made by the lateral pterygoid muscle that I wanted to show you. Those are the branch of mandibular nerve, 2 important for the pterygomandibular space, inferior alveolar nerve, and in front of is lingual. And here we will discuss it in the chapter of the nerve that I wanted to show you that the chorda tympani, which is coming from the fascial nerve, is going to the infratemporal fossa and it joining to the lingual nerve. This is one. And second, pay attention the passage of the lingual nerve. Extremely close proximity with third lower molar. Be careful when you do the surgical extraction of wisdom teeth, which is a routine. Maybe some of you had it. This surgeon must be absolutely, because it's a few millimeters. If you do some mistake, you cut the lingual nerve, you traumatize the lingual nerve, and you lose the sensation of the anterior 2/3 of the tongue, lingual side of the mouth forever. So that's why extremely important the passage of this lingual nerve. Here is very nice how the chorda tympani is attaching to the lingual nerve, and lingual nerve then is continue to the proximity of the third lower molar, then go to the tongue and floor of the mouth. And this is a place that how you inject the anesthesia and how you go deep and you touch the bone and then you inject the anesthesia in this region, not behind in this region. That's why it's important to touch the bone. When you touch the bone, you know that you are not in parotid gland. Then you can inject it. If you don't feel it, so never inject. This is one interesting thing that the doctor wanted to extract the wisdom teeth, and instead of taking out, he was pushing the wisdom teeth to the pterygomandibular space. You see? And here is the mandible, and here is the pterygoid muscle. And there are million structures who want to take it out. This is another interesting that the patient or doctor was doing injection to the pterygomandibular space, but I don't know if the patient was moved or the doctor was afraid, so the needle was broken. Here is the cross section in CT scan. And now what I said, mandible, masseter, pterygoid medialis muscle, and here is the needle in the pterygomandibular space. Yes? Spread of infection to the other region of the pterygomandibular space is important. To the spread of infection, this is just a slide that how the spread of infection is going to the different area. If there is an abscess in the pterygomandibular space, so you cut it inside and you go the drainage of the abscess. This is the retrostyloid part of the parapharyngeal space, and mainly is the content of the carotid sheath. So laterally internal jugular vein, once more, medially is the common carotid artery down or internal carotid artery up. Behind them, posteriorly is vagus nerve, and anteriorly the hypoglossal nerve is giving the ansa cervicalis, the superior root of the deep ansa cervicalis. Here, lateral to that is giving the nerve to the sternocleidomastoid, which is which nerve here? Yes? Accessory nerve. And medially, it's the glossopharyngeal nerve, which is supplying the muscles of the pharynx. And this is the same picture with the details, the structure as your reference. And this is, if somebody is interested and he wants to revise the simplified, the previous slide in the cross section, this is the same cross section with the netter, very nice picture that we said it, all this structure that it is in the parapharyngeal space. For the revision, you have it as a reference for your ever. Then the last chapter, it's the retropharyngeal space, and very important before to recognize the cervical fascia. You know, in the neck we have different fascia, mainly two types of fascia. Yes, if you remember this table with the content, then the next slide is just additional information. So concentrate and focus to this slide, yes? We have superficial cervical fascia and we have deep cervical fascia. Superficial cervical fascia is covering immediately under the skin, only covering platysma. So it means that you cut the skin, between the subcutaneous connective tissue, you will find the superficial cervical fascia, which is covering the platysma. Okay? This is first. Then you have deep cervical fascia, which has three layers. Superficial layer, peritracheal layer, and perivertebral layer of the deep cervical fascia. Superficial layer of the, be careful, is not superficial cervical fascia, is a superficial layer of deep cervical fascia, which is in English terminology is called investment fascia. This fascia is covering two muscles, sternocleidomastoid and trapezius. When you dissect, you will see. You come to the sternocleidomastoid muscle under the skin, you remove the superficial fascia, and you see that this muscle is covered by the fascia. This is investment fascia, or investing fascia, investing fascia, or the superficial layer. Then you have peritracheal fascia, the second layer. It has two portions, muscular portion, which is enclosing the infrahyoid muscle, visceral portion, which is enclosing all the viscera of the neck, thyroid gland, larynx, pharynx, everything that is in the neck region is organ. That's why they call it visceral portion. It means thyroid gland, trachea, esophagus, pharynx is enclosing by the visceral portion of the peritracheal fascia. Deep layer, the deepest layer of the deep cervical fascia is perivertebral layer, which is enclosing the intrinsic muscles of the back, deep muscles of the back, longus colli, longus capitis, scaleni muscle, and this perivertebral muscle, and sympathetic trunk, which is not mentioned here. This perivertebral layer has several layers. The anterior portion is called alar fascia. The posterior portion is called perivertebral fascia, or posterior portion of the perivertebral fascia. So this information that I put it in the table is necessary for you. The next following slide is just explanation for the details. So you see the peritracheal muscular portion is covering the infrahyoid muscle. You see the visceral portion of the peritracheal is covering the viscera, the organs, trachea, esophagus, trachea, pharynx, thyroid glands. This is the perivertebral fascia, the deep, which is enclosing the perivertebral muscle. Here is longus colli, and laterally is enclosing the sympathetic trunk. Here, the investing layer or superficial layer of the deep cervical fascia, which is covering here sternocleidomastoid and laterally trapezius. Then if you go cutting and go deep, here is peritracheal fascia, which is covering the infrahyoid muscles. Be careful, the carotid sheath that we said the content, internal jugular vein, common carotid, internal carotid vagus, this sheath is formed by peritracheal layer of the deep cervical fascia and perivertebral layer of the deep cervical fascia. You have it here. Then There is a space here. You see that infrahyoid muscle is enclosing. Here is the visceral portion. All the viscera here is enclosing by the visceral portion. And here is the paravertebral fascia. Here is the platysma. Under the skin, this fascia is superficial cervical fascia. This is investing layer, which is covering the parotid gland, sternocleidomastoid, and trapezius. And here, when you cut it, you go to the infrahyoid muscles and the organs by the paratracheal fascia. Then you have paravertebral fascia that it has two layers. The anterior layer, which is called alar fascia here. Posterior layer, which is normally is called paravertebral layer. So this space between pharynx, which is covered by the buccopharyngeal fascia, and the alar fascia is called retropharyngeal space. This space between alar fascia and paravertebral fascia is called danger space. They call it danger, is exactly the terminology. They call it danger space because if the infection goes there, very quickly it goes to the mediastinum and it's fatal. And behind, between the bony vertebra and the paravertebral list, there is a paravertebral space. So the retropharyngeal space, as a matter of fact, you have three potential space. The retropharyngeal space, the true one, danger space, and paravertebral space. And this is the sagittal cross-section. This is the paravertebral space. The red one is danger space, and the white one is the paravertebral space. And here is the explanation of those space that we mentioned. And the danger is that because down, there is nothing to stop it. No bone, no muscle, no fascia. Is a loose connective tissue which is going directly communicating with the mediastinum. And here is the cross-section, the same things for the carotid sheath, the structure of the parapharyngeal space. Those are the details, as I said. Remember that table that I said. This is how explaining how the tooth infection or tonsillar infection is going to the different area of the parapharyngeal space. It can go to the cavernous sinus, orbit, parotid gland, cervical tissue, the internal carotid artery, or the internal jugular vein, up and down. And those are the spread of infection. Between the superficial fascia and paratracheal fascia above the sternum, there is a interfascial suprasternal space, and here it's located the venous arch. I said it in the video, and you saw it, you will see it in the dissection in the neck region. So just remember that there is a suprasternal interfascial space. It's important for tracheostomy. When the surgeon will do the tracheostomy, he has to be careful of the venous arch, connection of the two anterior anterior jugular vein. So here is the abscess in the retropharyngeal and parapharyngeal, you see, and here is the drainage of the retropharyngeal space. And the last thing that already we said, this is a lecture from the oral cavity, and wanted to show you how the lingual nerve is crossing the submandibular duct, and it's the sublingual region. You have this slide and this lecture in the tongue region, in sublingual region, but I put it because it's one of the deep space in the head, and it's very important. Those are the boundary of the sublingual region, and here is the content of the sublingual region as a sublingual gland, submandibular duct, lingual nerve, hypoglossal nerve, vena comitans nervi hypoglossy, lingual vessels, and sublingual artery, which is here is all the content here is written together with the anterior process of the submandibular gland. There are some potential space that between the muscles, there are the potential space that if there is a tooth infection, this infection, it goes through this space and is making a life-threatening structure. This is another cross-section for the netters for this region, just for your reference. And what I wanted to, this is also, we had it in the submandibular duct and salivary gland, what I wanted to say, especially to know, and this is a question of the state exam of the dentistry, that the tooth that their root, they're finishing above the mylohyoid muscle, they are making the sublingual abscess. The tooth that they root, they are going below the mylohyoid muscle, they are making a submandibular abscess. Extremely important, the role of the mylohyoid muscle. And this is in vivo, and this is the in vitro when we dissect, and here when we operate, the removing of the tumor of the sublingual gland. And if all this space is full, it's called Ludwig angina, that we had a patient for the tooth infection that died because of this, because it's closing the airway and patient will suffocate for this one. The drainage is via the submylohyoid raphe to this region. You have this lecture and you can do the drainage, you remove the pus, and you avoid to cut these vessels and structure that it was in the sublingual region. The last slide is in the floor of the mouth. You have a pseudocyst, which is called ranula, because it looks like a belly of the frog, and there is a cyst in the floor of the mouth in sublingual region that it must be removed surgically. And thank you very much for your attention. Yes, on time.